Hello, and welcome everybody to today's webinar, Fluorescein Angiography-Free Planning of Navigated Retinal Laser Treatment in Cases of Macular Edema. My name is Stephanie Gerke. I'm Marketing Director at ODOS, and I'm happy to see so many people interested in navigated retinal laser online today. In the next approximately 30 minutes, we will give you an overview on how to use the multimodal planning capabilities of the Navilas laser system with a special focus on replacing fluorescein angiography for the treatment of DME and CSCR. I'm very happy to welcome today's presenter, Dr. Dmitrii Maltsev from the Ophthalmology Department at the Military Medical Academy in St. Petersburg. Dr. Maltsev has the Navilas laser system already since 2014, and since then he has intensively studied how to use multimodal diagnostics to perform an optimal laser treatment. Today, he will share his experience on the use of en-face OCT for replacing FA and DME and CSCR treatments. Navilas provides the ability to overlay these diagnostic images onto the fundus image captured with a Navilas laser in order to plan and to perform an image-guided navigated laser treatment. Dr. Maltsev's short presentation will be followed by a question and answer session. To type in and send your questions, please use the chat window, which you find on the webinar application. We will try to answer as many questions as possible during the Q&A session, and any remaining questions which are not fully covered today will be answered offline after the webinar. So don't worry, if your question has not been selected, nothing will be missed. But now, let's get started with the presentation, and with this, I hand over to Dr. Maltsev.
Hi, everybody. It's a pleasure to be here. Thanks to organizer for this kind invitation. Today, we're going to talk about fluorescein angiography-free approach for navigated laser planning in different disorders. Here's our agenda. Specifically, today, we're going to talk about treatment of diabetic macular edema and central serous choroidopathy, including acute and chronic cases. And we will start with introduction. And third thing, what I would like to discuss is that we are living in anti-VEGF era today. But I strongly believe that laser is still an adequate, very good and safe option to treat some retinal disorders, specifically macular disorders, including diabetic macular edema and CSCR. And several things are important. First, we should remember the laser systems what we operate with today are significantly different from those we had 10, 15, and of course 20 years ago. The laser systems became more precise, more predictable, and having more new options like a micropulse laser and specifically navigated approach. Another thing, what I would like to remember, that anti-VEGF therapy is not only alternative, but also very good adjunct to laser treatment, and combination is a very good and safe option to treat many retinal disorders. And the third, maybe the most important thing what I would like to remember, today we're the diagnostic revolution, which give us many diagnostic modalities what we never had before. It is high definition of OCT, different wide field options, OCTA, scanning laser ophthalmoscopy. All these modalities facilitate our laser treatment and give us more and more good outcomes. But one limitation of laser is still alive. It is a requirement for fluorescein angiography. And when we talk about FA, we should remember, of course, adverse reaction which associated with these modalities. And Nusi and Fitorovich reported many of them. But I believe that there are other limitations for FA, including requirement for technical equipment, some additional facilities, additional training personnel, and more importantly, the time, because in our busy daily practice, fluorescein angiography just not convenient modality, just not very good for our time limitation. Of course, today we are having OCT angiography as a good alternative for fluorescein angiography, but mostly, I believe, mostly for a diagnostic approach, not for laser planning, because OCTA cannot show us many aims to treat retinal disorders like leakage point, areas of diffuse leakage, and aneurysms. These is just limitations of OCTA. Of course, other multimodal imaging modalities can show us information about distribution of these aims for laser treatment. Unfortunately, these modalities just hard to be used for conventional laser just because appearance of classical orientiers like vessels or crossing of vessels is altered, and additionally the images can be too small. Just remember that OCTA image typically occupy just 6 by 6 millimeters. It's just difficult to operate in conventional laser. Fortunately, today we're having a navigated approach which gives us an opportunity to overlay just any image of multimodal visualization on baseline fundus image and plan and perform laser treatment. And I believe that the combination of navigated approach with on-fast imaging is very, very good and useful options. And we now discuss the application of on-fast imaging with treatment of diabetic macular edema. I believe that these options is very, very good to treat microaneurysms, because today we are now from recent papers that microaneurysms of deep capillary plexa are very important in pathophysiology of diabetic macular edema, and treatment of these microaneurysms is very, very useful and gives us a good outcome. But no other imaging modalities, including OCTA or structural OCT, cannot depict all these microaneurysms over the entire macula, but on-fast image can. And our recent study was aimed just evaluate which characteristics on-fast image can allow us discriminate microaneurysms in terms of their leaky status. We just overlaid on-fast images on FA and described the characteristic of microaneurysms, and we found that leaky microaneurysms on FA characterized by moderate reflectivity, absence of capsular structure, and presence of neighboring intraretinal fluid. All these characteristics allow to identify leaky microaneurysms. Like on this slide, you can see that the leaky microaneurysms are moderately reflective, in contrast to non-leaky ones, which are highly reflective and having a capsular structure. Cumulatively, all these characteristic reflectivity, capsule structure, and presence of intraretinal fluid allow us to achieve sensitivity and specificity 84 and 98% respectively, and cumulatively depict almost 95% of microaneurysms of those which we are typically see on FA. But the efficacy of using of on-phase planning is still unknown. So we performed another study where we treated diabetic macular edema patients using focal laser planned on fast OCT or fluorescein angiography. We define central retinal thickness and macular volume, and of course best corrected visual acuity. You can see the baseline characteristics of study groups here. You can see the groups are very, very similar, the same age, BCVA, retinal thickness, the same number of microaneurysms, and of course, number of laser pulses using on-fast and FA images. And this study showed that there are no difference in CRT change of central retinal thickness and macular volume, and of course best corrected visual acuity between different imaging modalities to plan focal laser. And you can see here the first example of this central involving focal diabetic macular edema, and you can see a few microaneurysms close to the fovea, which were treated by focal laser with complete and stable reduction of diabetic macular edema. The total follow-up up to date more than 1.5 years, and this patient is stable. Of course, such a simple case can be easily planned, but what about more complex cases like this, where number of microaneurysms is very high? Of course, you can divide your treatment into sessions and treat all microaneurysms. Also, with good and stable results, as you can see, subretinal fluid completely reduced with macular volume and restoration of visual acuity. So I strongly believe that on-fast planning of focal laser photocoagulation of microaneurysm in diabetic macular edema is a good, very effective and very safe options compared to fluorescein angiography, is at least non-inferior compared to fluorescein angiography planning. So we can go to another application for fluorescein angiography-free approach, specifically in central serous chororetinopathy. Of course, it's one of the main indications for focal laser, I mean, non-resolving acute cases, and it's considered that fluorescein angiography just unavoidable to perform focal laser in that case, but is it really so? I believe that no, because our recent studies showed that you can use many OCT structural OCT characteristic to define leakage point, and one of them is pigment epithelial detachment, which coincide with leakage point in the majority of cases. We found 8% of coexistence. Another thing is photoreceptor autosegment layer thinning, which indicate leakage point in 90%. And combined to these features, you can identify a leakage point clearly enough to perform focal laser in many cases, especially if you use additional characteristics like specific spatial distribution of leakage point in upper half of neurosensory detachment and in upper half of macula. You can see the specific distribution and can help to plan focal laser because you can exclude findings below the center of the macula as a possible source of the leakage. And the practical application of such an approach in this key series, you can see that it's included 16 patients with non-resolving CSR, showed that this approach is very effective and safe, and all patients meant the complete resolution of subretinal fluid. And here some of such cases. You can see this 30 years old asymptomatic man with stable subretinal fluid. You can see that fluid is stable over almost 3 months. It's truly non-resolving cases. And you can see also this small pigment epithelial detachment and photoreceptor autosegment layer thinning over it. And this is only one possible source of the leakage in this case, and you can plan and perform laser, followed by complete and stable resolution of subretinal fluid. Another case, very interesting because this myopic man was treated as a patient with myopic CNV in another clinic and even received 2 anti-VEGF injections, of course, without any results. But we define this patient as a patient with CCR because you can see this small connection between main area of subfoveal fluid and small pigment epithelial detachment. You can see the small connection, and the source of the leakage actually associated with this pigment epithelial detachment. This area was chosen as aim for focal laser. You can see the plan here, followed by complete and stable resolution of subretinal fluid and restoration of visual acuity. So I believe that fluorescein angiography-free approach is really possible for at least some non-resolving CSR cases, but the main point here is appropriate selection of patients. You should choose non-complicated cases with a single pigment epithelial detachment clearly placed in upper half of neurosensory detachment with pore-thinning over it. Other findings like RP ribs, washout of subretinal fibrin also can facilitate this planning, but they're quite rare. Another point what I would like to discuss today is a combination of fluorescein angiography-free approach with micropulse laser, because micropulse is very effective option to treat chronic CSR, the condition what can be hardly treated with other approach. And the main point of micropulse is safety. It's caused no damage, no death of RP cells, and lead to expression of many biological active molecules which reduce subretinal exudation and restore normal anatomy of the retina. And here's several examples. One of them is this lady with chronic CSR. You can clearly see this gravitational track on on-face image, which associated with this area of RP irregularity. Please note that there is no CNV here. The signal on OCTA image very weak and probably is artificial. So we choose this patient for micropulse laser, and we choose this RP irregularity area as the aim for treatment. And you can see that fluid after treatment completely reduced and was in this condition was stable over several years of follow-up. And another case which looks more like acute, you cannot see significant RP irregularities, but cord very thick. You can see this large vessel and pro-thinning over this. There is no CNV in that case. OCTA is clear, but the area of photoreceptor autosegment layer thinning is quite broad and doesn't allow to identify focal leak precisely. This patient was stable over months and she was symptomatic several months before, so we choose active options and we choose micropulse as a treatment option in these patients. We choose relatively large area of RP irregularities as the aim for laser treatment and cover them it with laser spots with quick and stable result. This patient is under observation now because subretinal fluid is not completely reduced yet, but I believe that it's finally come to complete restoration. In conclusion, I believe that combination of navigated microsecond pulsing laser and fluorescein angiography-free approach is a very good and safe option to treat chronic CSR cases because both sides of this approach facilitate each other. Non-invasiveness of this approach, avoiding of FA, eases the decision to perform laser specifically for patient, and vice versa. Safety of microsecond laser reduces risk associated with possible, I believe that it's highly unlikely, but possible misidentification of the leak. Thank you for your kind attention. If you have some questions, I would be happy to give you an answer.
Thank you, Dr. Maltsev, for this already in-depth presentation. We will now move on to our question and answer session. And as a reminder, to type in and send your questions, please use the chat window, which you will find in your webinar application. And again, we will try to answer as many questions as possible. If your question is not answered today, we will do that offline after the meeting. Dr. Maltsev, are you ready to answer the first question?
Yeah, I'm ready.
Perfect. Give me a second, and we already have a first question. You mentioned that basically you can now replace the fluorescein angiography in CSCR and DME. In how many cases, more or less, do you still need to use FA?
How many cases I need to learn? Yeah, I'm correct.
How many cases you still need to use the FA?
Oh, to need. In our daily practice, I'm not use FA to plan diabetic macular edema completely, and not more than maybe 20% of CSCR non-resolving cases. I think that's the right number.
Okay, so for the majority of cases, you can perfectly work with the on-face OCT approach, correct?
Yeah, you're correct, because We use on-fast mode as the primary choice to plan any laser procedure for focal laser for diabetic macular edema and central serous choroidopathy. And for patients with CSCR, we perform FA only if one treatment was unsuccessful using on-fast. But as I said, this number is not very high. I would estimate them this case is not more frequent than 20%.
Thank you. Based on this question, there's a second question which is more related to the learning curve for this treatment approach. So everyone kind of knows how to interpret a fluorescein angiography image, but how much time do you think it takes a younger resident to interpret the on-fast OCT in order to learn this FA-free approach?
Thank you. That's a very interesting question. I would suggest to start from diabetic macular edema because that's more easy to identify microaneurysms than leakage point in CSCR, and then go to CSCR cases. Just learn correlation between FA and structural OCT in cases which good looking on both of these modalities. And I would say that 8 to 10 cases nicely depicted can be enough to learn this approach for diabetic macular edema and CSCR2.
Okay, thank you very much. I see another question. I mean, you have presented different approaches and you were also talking about microsecond pulsing. So in which cases do you decide to use subthreshold treatment versus threshold?
Very interesting question too. I would say that there is two main categories of patients who we decide to treat in microsecond pulsing way. First, of course, it's chronic CSR with flat irregular pigment epithelial detachments, and like one of the cases I've showed before. And another category is patients who demonstrate no features of focal leak without, for example, well-defined pro-thinning. If the pro-thinning are quite broad, it's difficult to define causative PD, etc. So if you just cannot define focal leak, it's more easy to perform microsecond pulsing laser.
Okay, so that means in more diffuse cases.
Yeah, exactly.
Okay, so give me a second. There's one more question specifically on DME treatment. So you said that in the ENFAS, you can see more microaneurysm type structures. How does this affect your treatment plan? Does it change, for example, the number of laser spots that you place?
Yeah, that's also interesting because indeed on-fast OCT demonstrated more microaneurysms than FA, and we believe that that's microaneurysms just on different stages of evolution, and they can leak in the futures. So we choose to treat a little bit more microaneurysms, which we see on FA, just all microaneurysms visible on fast mode in the area of accumulation of intraretinal fluid. So we believe that it can be have some characteristics of prophylaxis. I would say in quotation prophylaxis, of course, in quotation.
Okay, interesting. So I have another question here in the window. So you mentioned that the fluorescein angiography is a very time-consuming procedure. So on the other hand, with the on-fast OCT, do you maybe use more of your, let's say, expert time to interpret the images? So is the approach faster than FA-based treatment? How would you judge that from your practice, from your daily practice?
Of course, I believe that on-fast mode is much more easier to fade to be performed. It saves significantly your time. Instead of 20 to 30 minutes, you need to perform a FA or waiting while patients will be examined with a FA. You can just do OCT in a few minutes and save another half an hour. I think it's significant time saving for our daily practice. Just spend 2 or 3 minutes for OCT instead of 20-30 minutes for FA.
Okay. Thank you very much. I have one last question, which is concerning the outlook for this treatment approach. So what do you think, which aspects still need to be investigated to further kind of promote this treatment approach in daily practice? And have you, for example, thought of a kind of an automated approach of analysis as well?
Yeah, and that's a very, very interesting question, because now we are working on really working on automatization of such approach, first of all for CSCR, and we believe that technologies of machine learning can facilitate such type of planning, specifically for specialists who are maybe not so experienced in detection of leakage point with or microaneurysm with on-fast OCT, and the first results are quite promising, and we believe that in future this approach both for diabetic macular edema and central series can be at least semi-automatic, or maybe ideally fully automatic. Just a program which will indicate the preferable aim for laser treatment.
Thank you very much. We are already running out of time, and if there are any more questions on this very interesting topic, of course, we are happy to answer them offline after the webinar. So for now, thank you very much, Dr. Maltsev, for this interesting presentation and discussion. I enjoyed following this webinar a lot, and I hope our audience feels the same. We will inform everyone when the on-demand version of this webinar will be available, and we will also reference your interesting papers on the topic in this email. In the meantime, if you are interested in more clinical experiences and also case examples, webinars with navigated lasers, please visit our website forum at odos.com/experts. And also, if you are still working with a slit lamp-based laser, please note our recently launched entry to the world of navigated laser, which is the new Navilas Pro, available at very competitive pricing and also growing with your application needs. So in case you're interested in very precise and reliable, fast and comfortable laser treatments, please visit our website at odos.com Navilas Laser System, or contact us at sales@odos.com. So thank you very much for your attendance today. Have a nice day or evening, and I hope to see you soon online again. Bye-bye.